Welcome to the RSM. I'm Gillian Leng. I am the president, and I am not playing a big part in this evening's event, but I would very much like to welcome you all here. How many of you are members of the RSM? Pretty much all of you, but not all of you. So that gives me an opportunity to say it's a great place, fantastic events, lovely club. Do join. That's why. There was a notice up about a fire drill, which I hope you saw. We aren't expecting a fire, so if the alarm goes off, we have to leave. And I probably should also say, if there's an emergency, if you're feeling unwell, let reception know. They can find you help, but we usually have doctors in the building anyway. We're going to have a really interesting session on neuromodulation for neuropathic pain. It's an area I know a little bit about from previous life as a researcher, but not a great deal. So that's why I'm just the warm-up act here. And I do have to, most importantly, thank the funders of this event, the Alan and Sheila Diamond Charitable Trust. So big thanks to them for supporting this event. There are also some others I've been asked to read out who've also provided support. The Foot in Diabetes UK charity, the English Diabetes Foot Care Network, and the Diabetes Research and Wellness Foundation. So thanks to all of those as well. And you've probably heard enough from me, and you'd rather we got on with the session. So I'm going to hand over at this point to Dr. Abdul Lakhdar. Over to you. Thank you.
Thank you very much. Thanks a lot. My name is Abdul Lakhdar. I'm the current president of the Diabetes and Endocrine section of the Royal Society of Medicine. And, this evening on masterclass of neuropathy is really interesting, exciting, and important. As you'll, for the next hour or so, we're going to learn and exchange ideas and research about this entity. Is really, you know, why it's important and why it's very relevant as it touches, the lives and the quality of lives, actually, of many individuals, right? To start, let me start by initially Mr. Henderson is one of my patients. He was supposed to come tonight to obviously to tell us a little bit about his journey. But he couldn't because he was not well, so he has kindly recorded a video for us, which we are going to show now.
Hi, my name's Ian Henderson. I'm 68 years of age. I'm a type 1 diabetic. I first became a diabetic at the age of 40. I was the first person in my family, as far as I'm aware, to actually get diabetes. So for 28 years, I've suffered with this condition. And it's starting off, as I said, at the age of 40, diagnosed, entered into Whips Cross Hospital for 2 weeks, came out and was on insulin straight away. So type 1 diabetic, straight off. And I've been taking insulin now for 28 years. The problems with diabetes, as I'm sure you're aware, is astronomical. I started, firstly, for the first 5 years of being diagnosed, for some reason in my mind, I didn't think I was a diabetic and never took my insulin when I should have had. And then one morning I woke up having a shave and realised one of my eyes was full of blood, and that engaged my brain to then have to go and have an operation on my eye to clear the blood, and also started laser treatment on both eyes. So at that period of time I was 45 years of age. I'd been diabetic for 5 years, obviously. That engaged my brain to actually start taking my insulin and doing what you should do. 5 years later, at the age of 50, I had severe kidney problems, chronic kidney disease, to the extent I think it was roughly around about 38 of a function. So you have your eyes problem, you have a kidney problem, then it gets worse. You have neuropathy. The neuropathy ended up at a small cut in the bottom of my foot, which led to amputation of 4 toes. That was in 2008. 2010, they had left the big toe on my foot. 2010, that broke and broke down, and that was amputated. So, for the next few years, I was in and out of hospital probably about 15 to 20 times with infections, ulcers of the foot. Kept ulcerating in and out of hospital. The mental strain that it puts on your life, the anxiety of it is horrendous. It's a horrendous disease, and I pity anybody who has it. I try to carry on working as best I can, but sometimes you're so tired you can't. It's a tragic story, and at the present moment in time, as I'm speaking, my foot's infected again. I've had 2 operations since 2024 to remove bones from my right foot, and I'm hoping that we can get some peace. I'm back at the hospital, the Royal London, tomorrow. That's my story. I hope it doesn't upset you too much, and thank you for listening.
I think that's a very touching story, and we hear that from a lot of our patients, actually, despite what we do, but unfortunately, complications do happen, but they are preventable. At this stage, I'd like to introduce Dr. Ashish Shetty. He is the president of our Pain Society, for his, obviously, role. Please go on.
Thank you. How many of you currently treat or have treated diabetic neuropathy? All of you? Anyone doesn't treat here? Right, okay, so these are my disclosures. I have worked with industry a fair bit. I have a lot of conflicts, so don't believe everything I say. Find out for yourself. I'm also the president of section. I'm the regional advisor for London, so educational conflicts as well. So the objective today, I'll try to, in the 20 minutes, hold your breath. I'm going to go take you through a whistle-stop tour, and if you're interested, then we have a whole day meeting coming up soon. So neuropathic pain itself is a big challenge. Add diabetes to it, a bigger challenge. We'll discuss that. The evidence base, I'll present some, and possible guidelines for the management of pain. If you're treating that, you should be aware of the guidelines. Patient selection, possible treatment solution. I'm not saying I've got a perfect cure, but maybe one of the possible treatment solutions, and then we'll have a good discussion. So why this talk? This is the bottom. I've given you reference. We published in Nature the effectiveness of medications in neuropathic pain. When the initial study comes up, it's an industry-sponsored study, heavily biased and stuff, and then we eventually see years down the line, then we see the effectiveness is not so great. In real life, the same thing. Pain interventions, again, injections, we do it. Surgical procedures when things go bad, and physical therapy is required for all of this. But in spite of this, there's limited or ineffective therapeutic options for this difficult condition. And this is just looking at UK. You see that there's a huge population there that is diagnosed with diabetes mellitus. 20% of them then have the neuropathic pain, and almost half of them, the pain is refractory. And usually the way you treat is mainly pharmaceutical options. Anticonvulsants like pregabalin, gabapentin, duloxetine, amitriptyline, capsaicin 8% patch, lidocaine if you're lucky to get it. The patients usually come with a lot of different sensations. It's a combination of neuropathic pain. They say they won't, and these are some of the ways they describe their pain, which is classical of neuropathic pain. But where it gets difficult is this. They have paradoxical sensation. They say it is numb, but it's painful. And a lot of people don't understand it. They say, if it's numb, how can it be painful? You're coming to a pain doctor, I numb pain. And you're saying, your feet is numb, yet it's burning. And these sensations can be difficult for patients to express and doctors to understand. And this is because there's a complex pathology of nerve damage underlying these conditions. In terms of conventional therapy, that's our paper, and it's had about 6,000 downloads now. Essentially, most of the medications, the way they publish is small group of patients, small follow-up duration, and these numbers can be challenged, and they have been challenged. The number needed to treat generally is not as good as it's shown on the publications here. But essentially, the medications for management of neuropathic pain remains elusive. So this is briefly about our paper. I'm not going to spend too much time on this. We analyzed all the papers that exist in pain medicine, roughly 450,000 papers. Of that, we went through the number of patients that came into this analysis was 27,000 to come to the conclusion of what we came. And in terms of neuropathic pain with diabetes, we find that patients already have to take a lot of medications, their insulins, their metformin, they've got kidney problems, the heart problems, and so on. So the compliance to these medications is low because they say it's not working, why should I continue? And the doctor is upping the medication all the time, and if they do adhere to it, they end up being on industrial doses of these medications most of the time. So, introducing spinal cord stimulation. What is spinal cord stimulation? Have you guys heard of spinal cord stimulation? Who's not heard of spinal cord stimulation? If you haven't, you're in the right meeting. So, who's not heard of spinal cord stimulation here? Only one, two? Okay, so quickly, spinal cord stimulation, we stimulate the dorsal columns. So we place a wire in the epidural space to stimulate the spinal cord. It's connected to a battery. It's very similar to a pacemaker, except that this is sitting on top of your spinal cord. So the principle is it disrupts the pain signals traveling from the painful bits, which is your feet or your hand, to the brain. It's not a major surgery, and it's a fully reversible surgery, just like a pacemaker. To implant, it takes us about roughly 60 minutes. To take it out, it takes about 20 minutes. It is expensive because the device, the technology, is expensive. Worldwide, about 30 to 40,000 implants done for neuropathic pain in general. So it's a procedure that's been done since 1980s. In the last 20 years, it has picked up, so it's not a new therapy. Again, the components, battery and the wire. So it's a simple setup. The way it works is it delivers electric current to the spinal cord, interferes with the pain pathways, and confuses the brain, so the pain from the feet doesn't go to the brain and modulates it. And the common question is, oh, so it's not fixing the problem. Generally it isn't, but I'll show you a study in a minute. History of electricity in the management of pain is one of the oldest therapies. It's a busy slide, but what I want you to see here is Egyptians used the eel from the Nile to treat pain and gout. Romans used it for treatment of headache. And where our pain clinic is based at UCL, 1768, there was a department of electricity. So I'm there now. Guy's and St. Thomas, where I trained, 1836, Golding-Bird had a department of electricity. He published, and he had treated over 12,000 patients with electricity. And again, we did the high-frequency stimulation's first study ever in 2010 at Guy's and St. Thomas. And one of the study I'm going to present is based on that therapy. Science, everyone thinks, okay, this is a therapy, it's an expensive therapy, the industry is pushing it, is there science behind it? So quickly, I'm sorry for the animal lovers here. So the way we study any neuropathic pain condition, this is one of the animal models. So we expose the hind paw here. The sciatic nerve is a long nerve that you have in your leg. The rat has a similar nerve. We crush the nerve, and we create neuropathic pain here. And it's sitting on this mesh. We stimulate the hind paw and measure the response. So you're stimulating. This is one fray filament, so you can give a graded stimulation to this hind paw. And quickly, and then we implant a miniature spinal cord stimulator implant in this rodent, which you saw here. This has got a spinal cord stimulator here. And you measure the response. The green is the normal paw, and it takes about 20 gram pressure for it to withdraw the limb. Imagine you're sitting and someone is poking you. Initially, the gentle touch is okay, but if they're getting too annoying, then you say, what the hell is going on? So normal at 20 grams, only then it withdraws. But when you crush the nerve, it starts withdrawing at light touch, 5 grams. That is what we get in diabetic neuropathy. Light touch hurts. Touching, putting your socks hurts. Wearing your shoes hurts. So that is because at lower thresholds, it starts firing up the neurons. Then we implant with spinal cord stimulator, and look what's happening to the response. That hind paw, which has a crushed nerve, does not withdraw until 20 grams. So it has come back to the baseline or normal. We stop stimulating, it comes back. So no placebo, no bias here. It's a rodent. Okay. So quickly, I'm going to talk about our spinal cord stimulation. Is there evidence base in humans now? So essentially, because we have very little time, I'll quickly show there are a lot of RCTs done. And pre-high frequency stimulation, it was Medtronic. And you can see they did the studies up until 2014 in patients with diabetic neuropathy, painful diabetic neuropathy. And they had a responder rate about 50 to 60%. And this is a conventional stimulation of the spinal cord, where the pain relief comes by causing a buzzing sensation. So you already have pain in your leg, you cause a buzzing sensation. So some patients don't like it. Come 2016, by then we had the high frequency. The difference is with a high frequency stimulation, you don't get any buzzing. So you get pain relief without a buzzing sensation in that limb. And so there are RCTs, and I just put the salient RCTs here. And with this one, you see the responder rate has gone up. What do we mean by responder rate? More than 50% of the patients get over 50% pain relief. Okay. So I'm going to take you through this paper, which is a 2-year follow-up of patients with diabetic neuropathy. And these patients predominantly had lower limb pain. And this was 18-center study in the US, 216 patients randomized into 2 groups. One went into conventional management, as you do, and one went to spinal cord stimulation therapy. And the patients had an option after 6 months to crossover. So patients who had the stimulation had an option of saying, I don't want this, switch it off. Or the patient who didn't have the stimulator said, I want to have the stimulator. And guess what? Most of them chose to come to the stimulator group. And 93% of the patients crossed over to the treatment arm. So it was intention to treat study. And so with this therapy, there are several publications. 6-month study was published in JAMA Neurology. 12 months was published in Diabetic Care. And 24-month published in Diabetic Research and Clinical Practice in 2023. And subsequent 4 years outcome has been published now. Again, this, I'm not going to bore you at this hour with this, but essentially what it says is that how many patients were trialed. That is 181. 171 had a positive trial. So you don't have a full implant straight away. This is a try before you buy kind of therapy. You have a temporary wire put in for 2 weeks. In this case, 1 week. We do it for 2 weeks. And at the end of that period, if you say, wow, this is fantastic, I want to have a full implant, you take the wire out. They come back in 6 weeks, and we do the full implant. Okay. So 171 had trial success, of which 154 were implanted, and patients have a choice of dropping out, or patients can have other medical problems, other surgeries, pregnancy, and so on. So not everyone proceeds. And 142 continued at the 24-month follow-up period. So quickly, in terms of male, female, not a huge difference. In terms of diabetes, type 1, type 2, duration of diabetes was roughly over 10 years in all cases, shows the delay in referral of these patients for the therapy. It takes 10, 12 years for patients to be sent for adequate pain management. And they were only picked if their diabetes was well controlled. So HbA1c was less than 10%. So duration of pain, they should have had pain for at least 6 months. In this case, the average was over 10 years. Sorry. They didn't have any other medical problems that needed emergency surgery. They had tried the conventional treatment, that is anti-neuropathic medications, physical therapy, and they had exhausted the treatment control, and their pain was moderate to severe. So screening and diagnosis, again, I'll run through this quickly. So they had usual annual assessments, neurological assessments, and if they required nerve conduction study, they would have that. A trial procedure, this is what it looks like. We do an epidural injection, put the wire, and it's connected to a battery on the outside. So, and at the end of the trial period, you just take it out and pull it out in an outpatient. Nurses do it for us. So you're as good as new. Then, if the trial is successful and they want to go ahead with the full implant, you put the wires here. This is a X-ray of the spine, AP view. It shows the leads are placed around your thoracic spine in the epidural space. And this is the lateral view. So it's in the epidural space. It's connected to the battery. I'm going to quickly show you some of the patients that were implanted in this study. So 73-year-old with 15-year history of diabetic neuropathy, HbA1c 7%, had tried Lyrica, gabapentin for 10 years, non-steroidal, Tylenol, had pain score of 7 out of 10, burning sensation, numbness, and I'm not going to say what he said. And this is another patient, 48-year-old, type 2 diabetes since 2007, pain since 2010, HbA1c 8.1, BMI 44, taking Lyrica and few other medications on insulin. And a lot of these patients these are your classical patients, you saw the video, so most of them very similar. Again, young patient, 35-year-old with type 2 diabetes, younger one, early referral, 1.5 years of diabetic neuropathic pain, extensive cardiac history, peripheral vascular disease, recent chest pain, coronary artery hypertension. He could not start his blood thinner, so he did not qualify for the study. So you don't implant everyone. If they have other medical conditions going on and they can't stop their blood thinners, you don't have it. Evidence-based is a busy slide, but essentially what it shows is drop in the pain scores and follow up at 3, 6, 12, and 24 months. So responder rate, I've just simplified it here. So responder rate, 90% of the patients responded to the trial. They were suitable for a full implant. And in terms of profound responders, so 90% had more than 50% pain relief. Of these, 66% patients had profound, that is over 80% pain relief in the trial. And 80% mean improvement in the pain score was reported by the subjects. Where does it stand in terms of other medications and other conventional management? This is number needed to treat. Not a great matrix for studies, but one of the matrix. I wouldn't hang my coat just on this number, but it's less than 3 in terms of number needed to treat. So how many patients do you need to treat before they get better? For your medications, this is actually from the industry studies. In fact, there's no medication that has less than 10 number needed to treat in the revised studies. So with the spinal cord stimulator, it is less than 5 for neuropathic pain, and this has reflected for diabetes as well. The interesting bit was there was sensory improvement. So most patients reported significant improvement in dysesthesia. Dysesthesia is abnormal sensations that you feel, like buzzing sensation, not necessarily pain. And there was improvement in burning, tingling, numbness, and cold sensation. So I was asked to briefly touch on sensation like numbness and outside pain. So these patients actually reported improvement in other sensation in addition to pain. So the quality of life was improved just beyond pain improvement. So twice as many patients were at lower risk of developing diabetic foot ulcers because the sensation and ability to feel painful stimulus was better. And these improved sensation may help prevent complications from the neuropathy itself. So healthcare utilization, end of the day, it comes down to money. So 78% of, so in terms of opioid dose reduction, 78% there was dose reduction at 12 months. 37% of the patients stopped taking opioids. And 92% of the patients reach the level that we think is meaningful for a reduction of a drug. So if you reduce from, say, 10 milligram to 9, it might not be significant, but if you reduce from 10 to, say, 5, it's significant. So there are metrics for that. There's a statistically, and this showed that you had to spend less money on the drugs, less money on healthcare visits. And once the study was only protocoled for 2 years, but what they did is they followed the patients up at 4 years. So they did a survey, and not everyone responded, and there's usually a huge dropout outside the study period. But there were still 57 patients who responded, and they saw that they did not lose their efficacy. So they continued to get the pain relief beyond the study period at 4 years. Interesting observation is not only it helped pain, it also helped control diabetes. So it's probably not a direct effect. The potential mechanism is they got more active, they got fitter, their diabetes was well managed, they could do exercise. So better lifestyle, exercise, better sleep, improves metabolic function, stress reduction. So in addition to pain, there was better control of diabetes in this group of patients, which was demonstrated by measurement of HbA1c. Safety profile, it is at par with any implant device. Generally, any implant, the risk of a spinal cord stimulator, we quote the risk of infection is about 1 to 5%. This is at the higher end of 5% because diabetic patients are prone to infection. 5 patients required explant, which is 3.2% of the implanted patients. Otherwise, safety profile, no significant complications like permanent nerve injury or paralysis, gallbladder sexual dysfunction. So the evidence from this study and the other RCTs is in terms of management of pain, there isn't at the moment better evidence for pain management compared to other modalities. It has got the lowest number needed to treat. The efficacy is maintained at 4 years, definitely for 2 years, which has been published. And there might be a protective benefit in terms of getting your sensation back and the dysesthesia. So I've got the last 30 seconds. I'll quickly run through this. I'm not going to talk about this. Again, there's a study going on to check if it improves your nerve functions and sensory. It's at this stage. They've enrolled 143 patients, and hopefully in the next meeting, I'll get to that. So I showed you this at the beginning, how we treat. The current recommendation is once you have exhausted this, if you're not able to manage, rather than saying it's a difficult condition, go home, consider of referral for spinal cord stimulation. Treatment guidelines. So this is not something that we are saying based on this study. There's a nice guidelines, TA159. If you don't know this one, you haven't tried. So it's been there since 2008 for treatment of neuropathic pain. Supported by several studies. Guidelines is supported by American Diabetic Association, AAC guidelines, the SWEET statement, ASPN guidelines. There's a strong recommendation for use of this. Patient selection is the key. It's not for everyone. So the pain doctor knows which patients are suitable. This is not a suitable patient, so don't send patients who have got head-to-toe pain and we haven't taken a good history. We just say, oh, he's got terrible neuropathic pain, but he's got severe migraine, chest pains, endometriosis, and other conditions. So this is what the referral pathway looks like. There's a huge exclusion criteria, and because of lack of time, I'm not going to. Quick one. René Laennec, the father of modern auscultation, he rolled a piece of paper and a stethoscope was born. But when he described this, everyone jumped at him and said, we are losing the intimate connection with the patient. How dare you suggest that we use stethoscope? So evolution, people who jumped out of these trees, freed up their hand, and they could invent tools. So the question is, are you ready to jump? Thank you.
Thank you very much for that. It's now my turn. I'm going to address insight into the management of painful diabetic neuropathy. As you can imagine, obviously, when we talk about a topic, they're bound to be obviously repetitions of especially we're talking about, the same papers, the same research. Having said that, nerve stimulation obviously is fantastic. The only problem is expensive and is very limited. Its availability is very limited. But if you are lucky enough and you got neuropathy, and it's really a great sort of modality of treatment. Now, here we are. Now, I'm going obviously briefly to talk over the next 5 minutes, and hopefully we can expand during the discussion time. Now, so how to manage peripheral neuropathy? As I said, now our problem, and obviously I talk, from a diabetes, sort of a point of view. Now we see this quite a lot, and I'm afraid to say that the condition, both diabetic neuropathy and diabetes, and its painful moiety are underdiagnosed. And there is research for that to prove that. Now, I'll show you shortly. Now, NICE only approves mononeuropathy for diabetes, right? Although there is studies to show that you could combine them. Now, there are guidelines from both sides of the Atlantic, and when you look at them, they're quite confusing. And I'll finish to say a few words about the latest trial published in this area, and that's the option trial, diabetes and diabetes trial. Right. Now, I mentioned the condition is underdiagnosed, and as this study shows, only 50% who had diabetes, diabetic neuropathy, and with neuropathy are diagnosed. So in other words, we miss 50% of patients, unfortunately, right? Now, this study is important, and as you could see from a population from Germany, the Netherlands, Spain, and the UK, and the patient is asked with neuropathy, who diagnosed your diabetes? Your neuropathy. And you'll be interested to know that 41%, the majority, said that they're my diabetes specialist, followed by the GP, followed by the neurologist. So that's a real-life study, right? Now, I find this study very interesting, published in the New England Journal of Medicine, and it's from the Diab, and over 1,000 patients. They looked at the vascular risks for diabetic neuropathy, and you'll be interested to know that actually, the hypertension turned out to be as the #1 vascular risk factor for diabetic neuropathy. Is not the glycemic control, and is actually the hypertension. Why? Because actually the risks for diabetic neuropathy, we don't know them. But there are a number of vascular factors are very well established, right? Now, well, when we talk about the treatment of diabetic neuropathy, well, we not just talk about medication. Well, actually, there are a lot of management issues which are very helpful, and indeed, psychological support. Well, obviously from the approach of the physician, and listening is important. Addressing mood, sleep, functionality, explain to the patient, allaying fears, and teaching them about coping strategies. Physical measures, especially with the allodynia, and allodynia is actually where the patient feels pain with stimuli. Normally don't give you pain, like pajamas and things like this. Becomes very painful, and so on. Metabolic control is extremely important, right? And this exercise, regular exercise, non-pharmacological methods, so they're extremely important. Now, when we assess any anti-neuropathy agent, actually, the best result we hope for is 50%. Although, that should not, normally we say that realistic, but that should not obviously make us less aggressive in treating the condition and looking for other modalities to treat neuropathy. Now, Ashish mentioned a number of these agents, but just briefly, it shows you that now both in 2015, this is, the guidelines came from the neuropathies, sort of a specialist group, where obviously tells you that which agent was first line, like duloxetine, and calcium antagonist was first line as well, and the tricyclics, where like amitriptyline was first line, and so forth. Now, NICE, both in 2013 and 17, they agreed mostly, but obviously was a little down the line of disagreement. Now, it shows you here that's when we compare all the various learned societies, both sides of the Atlantic, and Europe and America and Canada as well, you'll find obviously the known drugs that Ashish have mentioned, Ashish, and they're listed here as well. Not all of them agreed. For example, now we know gabapentin and pregabalin, they do the same job because they belong to the same family, although pregabalin gives you less side effects. You know, some societies accept them as a first line, but others as a second line. And indeed, tricyclic antibiotics, tricyclic, antidepressants, well, indeed, they have been the mainstay for treatment of neuropathy as a first line for a long time, but other societies accept them as a second line, and so forth, right? Now, as I told you earlier, neuropathic pain management, drug management by NICE, they actually, they recommend only monotherapy, so they ask us to offer a choice of amitriptyline, duloxetine, gabapentin, or pregabalin as initial treatment. And after that, you replace it, right? Now, this is, indeed Now this is my last slide because I only have 5 minutes to address you. Now, and this is the study I've mentioned, published, and the Lancet, and it compares amitriptyline supplemented with pregabalin, pregabalin supplemented with amitriptyline, duloxetine supplemented with pregabalin for the treatment of diabetic neuropathic pain, and this is the option trial. And interesting enough, this is the second study in this context, because not long ago we had the combo study, which combined duloxetine and pregabalin, or vice versa. And to be honest, the benefit is quite similar. And again, the result of the study showed, whatever combination you do, you get a similar degree of pain relief. Now, I'm going to stop there because we can expand in the discussion. I'm going to invite my colleague, Dr. Farid Harizvi, who's a consultant colleague, to talk us about the painful truth. Neuropathy is outpacing our response.
Thank you so much, Abdul. Thank you for the invitation to speak. Apologies for my appearance. I've come from my ward round this morning where I saw a load of diabetics with multiple complications. So I'm coming, at this from the angle of a jobbing diabetologist, and it would be really interesting to hear everyone's opinions, at the end. So I have a few objectives here. We're going to briefly talk about the epidemiology, historic evolution of diabetic neuropathy, explore some of the etiology, a bit of a revision in basic physiology, and try and explore what we know and what we don't know, and what we don't know, and evaluate current treatment strategies, which we've already kind of touched upon, and assess the potential for reversibility, because diabetes essentially now, the conversation around diabetes has changed, and we're talking about reversal of diabetes. And how does that play into this epidemic of diabetic neuropathy? So as Dr. Lakhdar said, diabetic peripheral neuropathy affects about 50% of individuals with diabetes. Type 2 patients, because they have had diabetes for a bit longer, usually at diagnosis, 10 to 15% of them may have diabetic neuropathy at diagnosis. And some patients will have small fiber neuropathy, and I'll let our neurologists comment about that later. And that's something that they will often not pick up on. Painful diabetic neuropathy, which we've discussed, affects about 20 to 30% of diabetic patients, but there's a big burden of asymptomatic cases as well. And we've briefly mentioned foot ulceration, limb amputation as well. We heard, from our patient at the opening of this evening tonight, and this is the most expensive complication of diabetes without a doubt. The NHS expenditure on diabetes is really obscene, and within that, the expenditure on the complications of diabetes is extraordinary. So diabetic neuropathy is not a new thing, but the term was coined in the 30s and 40s, and better understanding has evolved with the advent of particular neurological investigations, such as nerve conduction studies, and some landmark trials in diabetes, mainly the DCCT and UKPDS in the 1990s, have strongly linked glycemic control to neuropathy risk and risk reduction. And there's other similar evidence around other microvascular conditions such as retinopathy. And recently, we have developed an interest in other contributing factors around the development and severity of diabetic neuropathy. So what are the causes and what are the risk factors? So high blood sugar, which is hypoglycemia, if that is chronic, so if you have chronically high blood sugar, it activates a pathway called the polyol pathway, and that generates reactive oxidative species. And that causes oxidative stress, which is very damaging to nerves. The other thing that happens is our small blood vessels are affected disproportionately with diabetes. A really strong contributing factor is dyslipidemia as well, and that's something that I learned as I was preparing this talk. Neurotrophic deficiency, particularly B12 deficiency, which is a very well recognized side effect of metformin therapy in particular, but the mechanisms are not very well understood. And all of this, so this milieu of abnormalities that's happening at a microscopic level leads to inflammatory cytokines. So we've mentioned the polyol pathway. Another thing that's really important to mention are the generation of advanced glycemic end products, so AGEs. Those are complex heterogeneous proteins and other similar molecules that have been damaged because of their exposure to high blood sugar, and those also in themselves also activate systemic inflammation. And another thing that I learned when I was preparing this talk is, and my clinical colleagues would be interested to know, that the pathway of this kind of abnormality is very different in type 1 and type 2 diabetes. Actually, there's different pathways that are activated, and we as clinicians tend to lump type 1 and type 2 diabetes and diabetic neuropathy all together, but actually the pathways are very interestingly different. So we've discussed a bit about the physiology, but what is known? We know that there's a dose-response relationship between high blood sugar and the risk of neuropathy. We know small fiber neuropathy precedes, the development of large fiber neuropathy. Pain perception can absolutely differ by phenotype, and it's our job as clinicians to help patients and recognize patients when they're in distress and help them, as Dr. Lakhdar mentioned, exercise empathy, and not, looking at the blood test in front of you and actually what the patient is telling you can be two completely different things. And neuropathy can occur in people with normal HbA1cs. So we're diagnosing more and more people with prediabetes now. And, I've seen a few patients with prediabetes and neuropathy. So it's not just that you have to have terrible diabetic control to develop neuropathy. And what don't we know? Why? Well, we don't know why some patients have painful symptoms while others have silent progression and they don't have pain associated with their neuropathy. We're not sure about the precise genetic factors that might be contributing or autoimmune factors. Again, type 1 diabetes is an autoimmune disease. That might account for partly the kind of different pathway that's involved. A big area in lifestyle medicine that's expanding at the moment is gut health. It's all over social media, it's all over the internet. Does that have a role to play in diabetes and diabetic neuropathy? I would certainly imagine it does, but we don't have the mechanisms to explain it. And why some patients with excellent glycemic control still develop neuropathy. And we're not sure about what contributes to spontaneous pain resolution in some cases. So reversibility, tight glycemic control has been shown again and again to reduce the incidence of developing neuropathy, but it's limited in reversing neuropathy once it's established. Interestingly, bariatric surgery, which was, perhaps the best treatment that we had for type 2 diabetes, for patients that were obese or overweight with type 2 diabetes has actually shown to improve nerve function. Other lifestyle interventions such as a low-carb diet and exercise is linked to nerve fiber density improvement in some very small trials, and some anti-inflammatory interventions also have future promise. We've talked a reasonable amount about the pharmacological options that are available, but another thing that I found while preparing this talk is that actually GLP-1s, that class of drugs which is become the panacea for everything and everyone, actually there's some good early clinical evidence that it can help with reversing established diabetic neuropathy. So take-home messages: we're facing a tidal wave and really a public health emergency when it comes to diabetes. I know this talk and this session this evening tonight isn't limited just to diabetes, but I'm a jobbing diabetologist and I am concerned with diabetes day and night. It's the thing that I think about all of the time. And if we don't recognize it as a public health emergency, we are looking at more and more expenditure, more and more complex patients, and fewer treatment options. Thank you. Thanks.
Thanks, Fariha. Our next speaker is Professor Christian Heiss, our President for the Vascular, Lipid and Metabolic Medicine. He will talk to us on the importance of neuropathy and vascular medicine.
Thank you very much. Now, I must say I'm loving this meeting because we bring very interesting, different people together. And when I heard your talks, I wanted to every time ask a question. I thought, no, we have the discussion at the end. And what we're missing here is the vasculature. You mentioned it a little bit, but I think the pipes play actually an important role that we haven't seen. And some of the symptoms we're ascribing to diabetic neuropathy could also be explained by ischemic neuropathy. Now, we as vascular specialists, I'm an angiologist, but in this country, mainly vascular surgeons would take care of these patients, radiologists, but I'm an interventionalist, and what I'm focusing on with my patients is limb salvage and survival. Those are the two things we focus on. While I think we should actually rather focus on pain, because pain is the first thing that patients feel, and the typical pain that you've heard about in vascular medicine or you know about is claudication. When people walk, the legs start to hurt. When the blood vessels get more narrow, they may have rest pain, and when the leg goes up, then the leg will hurt much more, right? We call that rest pain. And then when we think about neuropathy, we usually rather think about neuropathy as kind of a nuisance that takes away that hint that there is a vascular problem. So people with diabetes may not feel their feet, they get an ulcer, and you do an ultrasound, you think, damn, the blood vessels are completely blocked, and shouldn't we have done that before? However, one of the things I start to realize more and more, and in particular in preparation for this talk, when I do an angioplasty, some things may get better, some things may not get better, and that's one of the things I discuss with my patients too. And here's an example. Young patient, young lady, 50-year-old smoker. Now, when probing her, she told me that she had some degree of claudication problems with walking over the last few years. Why she came to me was that down there. So essentially an infected hallux, which then turned into quite extensive gangrene. She also complained about nightly rest pain, but also shooting pain. So just by listening to her, it sounded like neuropathic, but also close enough to a peripheral arterial disease problem. She is a type 2 diabetic, and she also had back pain. So another thing to think about in this kind of patients. She was only on atorvastatin, metformin. Her other risk factors like cholesterol and blood pressure were actually pretty good. Now, she came to us and said that somebody had measured her ankle brachial index, and it was 1, which is normal. Everything above 0.9 is normal, but monophasic. So what we did is, of course, we measured toe pressure. So that means people can also have narrowings kind of beyond the ankle. It's the ankle brachial pressure index, and so you're missing the stuff actually below. But one of the things we've started to do in our trust and also in the Brighton Vascular Network is to use quantitative waveform analysis, which can give you perfusion pressure independent of media sclerosis. As you know, when you compress a calcium tube, you will not compress it, and you think the blood pressure is whatever, 200, but in reality, you don't know how it is because the method is just not adequate in this situation. So what we did was, of course, a CT scan in that patient to think about revascularization. She had a blockage on her left side in the superficial femoral artery. I took her to the cath lab, did an angiogram, and you could see there was a blockage. Hardly any collateral. So another thing that you talked about, microvascular problems that people can develop, because classically, if you have a blockage of your superficial femoral artery, usually you will develop collaterals, don't feel it. So I did an atherectomy, used a drug-coated balloon to keep it open. The interesting thing here was that basically on table, her ankle brachial index only increased to 62%. And when she came back to see me at 1 month, and I tell you why I mentioned first it was only 62%. Number one, she was actually scheduled for an amputation of that toe because of osteomyelitis. She couldn't come because her kids had a birthday party. She didn't come. Now, when she saw me at a month, it had almost healed. So perfect. She didn't have any more claudication. The nightly rest pain was gone, and actually the numbness she talked about was also much improved. However, when I asked her how you do, and she said like, yeah, the walking is fine, it has almost healed, but I still, after the procedure, had a swollen foot, and it really hurt. It's kind of getting better. I went to the emergency department, and I still have that shooting pain. So there was still something left, and how I interpret that, and I will get back to that later, is that people that have very ischemic legs also are more prone to reperfusion injury, meaning that it really hits in that same spot. So for this talk, I looked into how many of patients with PAD have a neuropathy, and it's 83%. So people actually took measurements in nerve conduction studies. There are few studies, seven studies maybe altogether. 30% radiculopathy, large proportion actually spinal canal stenosis, which can mimic claudication too. 43% had diabetic polyneuropathy. Within the diabetics, it was actually 73%, but then 23 had ischemic polyneuropathy. And the interesting bit about that is when you look into the literature back to the 90s, you can see that it's actually really hard to distinguish between diabetic polyneuropathy and ischemic polyneuropathy. How they took care of that was that they basically looked at specifically patients without diabetes, and it was very similar in non-diabetic patients. And the interesting bit was also that some groups say it's primary sensory, others said it's primary muscular denervation. So basically a broad picture. All of them showed that there's a decreased nerve conduction, and the symptoms very similar to diabetic neuropathy. Another interesting bit is that in an ischemic leg, it's worse, and it's progressive over time, and to a certain degree, actually reversible. So we have quite an overlap between these two neuropathies. Now, this was actually just appreciated about last month. The American Heart Association kind of opened the box and said, actually, we have to think about peripheral arterial disease as a pain syndrome, and we also have to think about that in critical limb ischemia. It's more of a neuropathic pattern, while basically in claudicants, it's probably more of a nociceptive pain. So low oxygen, essentially. So now here's what I'd like to advise is, number one, maybe for you who not primarily deal with vasculature, when a leg hurts, look at the blood flow. If you can, don't use ABI and TBI, because even TBI, toe brachial index, may be false because of calcification, can actually spread to the toes. What we have started is to do quantitative waveform analysis, which gives you ankle brachial index and actually toe brachial index. Next week, it's coming in one of the European Heart Journal journals. Still in press, so we showed you can do that with toe pressure too. And for us, on the vascular side, that means we should look into neuropathy too, and potentially more often order nerve conduction studies and actually have a monofilament in our pocket, I think. Second to last slide, important bit here, And I think maybe that's a starting point today, that we engage into that problem in a multidisciplinary way, that you guys potentially take more of a look at the vasculature, because that's something you can immediately do something about. And I personally think these patients need to be aggressively treated, and symptoms can be quite diverse. Look at risk factor management. That's a typo, it's not 6, I meant 53, of course, or 7%. Smoke and cessation, exercise therapy, and also think about infection control, because infection can also give you pain, and if need be, go for source control and amputate the toe if need be. In terms of supportive care, you've already talked about everything. I wanted to mention that's the study where they combined different duloxetine, gabapentin, etc. So given 2 is probably better than just given 1. And here are the take-home messages. If there are lack symptoms, check for PAD, use waveforms. Consider ischemic neuropathy in PAD patients and treat it like critical limb ischemia, because it's end organ damage, it's potentially reversible. I think at this point we do not know how ischemic neuropathy reacts to a pharmacologic therapy, but what we know is revascularization can save your limb, and at least from my experience, the patients will benefit. Multidisciplinary care and need for more research to look more into ischemic neuropathy. Thank you very much. Maybe from here, because if we have a microphone, I can go around, because we've reached the point.
I think there's a Q&A session after the panel, so you can do panel from here and then you can. You could even combine the panel discussion with Q&A.
We could. We could. Are there any questions for the? I'm sure that everybody's burning to ask questions. I was. Please.
Yeah, my question is to Professor Shetty. We have a microphone.
I think we can hear.
Oh, yes. Can you hear me?
Yeah.
Yes.
Okay, so yeah, so a very nice presentation by all the speakers, and my question is to Dr. Ashish Shetty. I'm a urologist working in Hertfordshire, so I would like to ask, this spinal stimulation system, will it help the bladder and bowel symptoms as well?
Yeah, so actually I forgot to mention my conflict of interest. So pelvic pain is one of my main area of interest. And we do a lot of stimulation. When I say a lot, we do a fair bit of stimulation for pelvic pain conditions. So it's not for everything. We have done it for orchidectomy, post-orchidectomy pains, in post-hysterectomy pain, post-episiotomy pain. So if it's a neuropathic pain and if it's a focal pain, then yes, we can do it for pelvic pain conditions and abdominal pain conditions as well.
Because we do get some very troublesome patients, and they are going from door to door with testicular pain, and we could not find any cause.
Yeah. So refer it to the pain clinic. Generally, neuromodulation is the last step. We tend to say no to most of the patients or avoid the implants, because testicular pain, there's dual innervation, the viscera and the skin. The scrotum is L1, 2, 3, L1, L2, iloinguinal, ilohypogastric, genitofemoral. And the viscera is from the pudendal. So it's a lot of the time people do one block and they say, it's not working. And they don't, maybe they don't do it properly, I don't know. So we work it up. We do say on-table testing, L1, L2 nerve block, and then S2, S3 nerve block, on-table stimulation. If that works and the pain comes back, we do a pulse radio frequency therapy. We can combine it with ganglion impart block, hypogastric plexus block. And in a select group of patients, we have done implant. In fact, one of the cases I have is wheelchair to work in a young 26-year-old who had post-orchidectomy phantom testicular pain. And he's working now. I'm not saying we cured him. His pain relief was about 65, 63% now. But in select group of patients, yes, the answer is it can be considered. But
okay, thank you. Thank you very much. Thank you.
Dr. Freiter. Dr. Freiter.
Thank you very much for your talks. My question is for Dr. Faria. You mentioned that diabetic reversal could take place with low-carb diet, etc.
Yeah.
Was it actually reversal you meant, or remission?
Remission, yeah. I've often been, what's the word? Told not to use those two terms interchangeably. You're absolutely right. So diabetes remission is a concept that has evolved over the last 15 years or so. There's very many literature data out there. There's the particular study, if you're interested, which is the DIRECT trial, and that showed that low-carb diet under very rigid circumstances can lead to diabetes remission. Diabetes remission is defined as a normal HbA1c off of medication, so that's very important. And so, I guess it depends where you're seeing the patient in their journey. So whether you're in primary care, whether you're in secondary care, I have no hope of achieving diabetes remission in any of the patients that I see, mainly obviously because I do a lot of type 1, but by the time I'm seeing patients with type 2 diabetes, they usually have cardiovascular disease, retinopathy, and CKD. But there is an NHS program for diabetes remission. There's the Know Your Risk scores, there's the pre-diabetes program, so there's a lot of provision out there, and I really think that we don't refer enough, particularly from primary care. When I refer patients for diabetes remission, it tends to be when I do acute medicine, so if I'm seeing someone, with something else and I always check the HbA1c because I'm a bit obsessive like that, then I'll ask for them to be referred to a diabetes remission program. So I really think that's the only way we're going to be able to cope with the frank tidal wave of diabetes that we're facing.
Yeah, can I add, we can get diabetes remission in two ways, by intervention or by, as Freya has said, by diet alone. Of course, we have seen, obviously, type 2 diabetes remission in obese patients following bariatric surgery. Now, nowadays, we see a lot, and I have seen so many patients, who diabetes is remitted on GLP-1 receptor agonists, or dual GIP, GLP-1 receptor agonists. After they lose a significant amount of weight, that diabetes disappears, right? That's true. Now, the study was published in New England Journal of Medicine 3 years ago called the DIRECT trial. And that's by Mike Lean in Glasgow and Roy Taylor in Newcastle. They have tested 300 patients of diabetes, with type 2 diabetes. They're all on treatment. Half of them, they do whatever they want, and half of them, they deliver their meals, giving them 800 calories. Yeah. Obviously, these 800 calories by meal replacement, a lot of fibers in them. They don't feel any hunger, and at the end of I think 3 or 4 months, right? And those patients who have lost, right, 17 kilograms in weight, right, 70% of them became non-diabetic. So here we are, no drugs, no surgery, nothing, just by diet.
And may I just make a quick comment? I was just showing my colleague, National Geographic 12 weeks back. It's a very interesting article. It's possible to reverse diabetes, and even faster than you think. So if you're interested, it's a very nice article. You should read this.
And maybe as a comment, I also have the feeling in clinic quite often now I see patients that have a diagnosis on their list diabetes. Then I look at HbA1c and it's 42. Yeah. And so we always get in that discussion: do we still keep diabetes in remission as a diagnosis, like atrial fibrillation, or can we scrap it off the list? What do you think? Keep it on?
I think I would err on the side of caution and probably keep it on. I mean, that's from a clinician's perspective, but from the perspective of public health, coding, that sort of thing, I suppose that's a slightly different area. How much of a
one of the problems
burden,
is if they regain the weight, the diabetes will reappear.
Yes. And diabetes risk increases with time, right? So you might see them in a year and that A1C may have crept up, so.
Yeah, also I have the feeling some of my patients, they said, oh, I used to have diabetes, and then it kind of takes away the incentive. I've seen that a few times, that people then really came back, as you said.
Yeah, maybe I shouldn't say this, but my private clinic last night, I had a chap in his 30s. He was diagnosed with type 2 diabetes at the beginning of the year, just after Christmas, and he came to see me privately. I gave him a whole lecture, And he came back yesterday with an A1C of 36.
Yeah, if they lose weight, they do that, yeah.
So I know this is not my study. So I'll tell you a funny bit. So when the study came, we were very excited, and we said we'll be one of the centers. So UK was, I mean, it's a US study now. But you know what? The number of referrals we got was 0.
No, sorry, I
So,
think I didn't
so I'm not part of the study. So, this was a secondary. They never intended to measure diabetic control
Okay.
as a part of the study, but they noted that in over half the patients, the diabetic control was better.
I appreciate that. I just want to know if did they give a number? What was the
Yeah,
percentage
so
reduction?
there's a number. There's a whole slot. So
I
if
think
you
it
bring the
said
slide up, there's a
1%
number.
Is that- I
A1C
didn't-
reduction.
Yeah.
I think
catch
that's
that.
what I noticed.
Yeah.
1%.
So I mean, there's a whole study. It's a big study. So 20 minutes is hard to get.
They can come from any. I mean, last week I had a patient who had a hemoglobin A1C level of 110, which is
Yeah.
really, right? Came down to 43. You know, he was on Monjaro though, and lost weight and things like this. Yeah.
Okay, I'd like to make a little plea. Please, can we improve education so we're empowering our patients? Because at the moment we've got years of delays and it's a ticking time bomb. So it starts at the really basic level. There is a connection between fibre and the real basics of healthy living, walking, hydration with water, never start smoking, alcohol, sleep, and if you don't know some of the symptoms, you won't be able to report them, then therefore you won't make that appointment to start the ball rolling. And in my family's experience, the biggest problem was a lack of coordination between primary, secondary and tertiary. Unfortunately, they're all dead. But in their legacy moving forward, it's taking action at an earlier stage because what happened was entirely preventable. And they all ended up immobile with neuropathic, sepsis, organ failure. So it's a real toxic triad, and it's an increasing problem. We're spending a vast amount of money, but are we actually winning? Some of this is preventable, and it involves a lot of different professions, but it could really start with holistic care as well, so that that person knows who to talk to, who to report. Thank you. The biggest problem is accessing the neurologist, because they're very busy people, but all the people working together. Thank you.
Absolutely true. I mean, education in diabetes does wonders. And I recall a study some year ago done by Professor Andrew Bolton in Manchester, where patients with neuropathy, they taught them just to look after their feet. You know, just inspect the feet, do this, do that, do this, and after 1 year, those who received the education, they reduced their feet ulceration by 4/5, simply by inspecting their feet and looking after their feet properly.
Thanks a lot for the brilliant presentation. I have 3 questions for Professor Shetty, but maybe other people might want to jump in and comment as well. It's mainly with the spinal stimulation. I know there are some studies with frame study looking at obviously the effectiveness, etc. How do you compare the two? Because obviously frames is less invasive. My second question is...
Sorry, the first question is comparing which
frame study. So so there's the frequency, I think it's frequency modulation. Let me have a look. Yeah, let me just have a quick look. What's it stand for? I'll come back to it. The second question is, I know there's some evidence to say that it also improves peripheral vascular disease, the spinal cord stimulation, and what's your understanding of that? And the third question is, how can we refer patients if we think they will benefit from spinal cord stimulation? Because I'm not sure if every pain team have access to that.
So I'll answer your second question first. So the NICE guidelines that was written in 2008, the cover page says, if you look at the cover page, I don't know if they can bring up this slide, this thing. So it says spinal cord stimulation for chronic pain of neuropathic or ischemic origin. So one of the first indication was for the one you asked. And in fact, even for angina, there's a SB study which did a randomized controlled trial, CABG versus SES. Similar outcome. In fact, in the SES group, the risk of stroke was lower because when you have a CABG, there's a risk of stroke. With SES, the risk of stroke is less. But you know what? How many referrals we get for either vascular or ischemic pain? 0. Because they would rather do a surgery than have a stimulation. So we don't, the ischemic indication has almost died because of lack of referrals, not lack of patients. So the evidence is there, and it was written way back in 2008 by NICE. And if NICE has to approve something, it's really, really hard because they don't, it's not an evidence-based. It used to be clinical excellence, but now it is cost effectiveness. Yeah. So they look at cost rather than stuff. And they have given an evidence, guidelines to say, you could do this for ischemic pain. So that was your second question. What is your third question?
How do we refer patient for this?
So the beauty of NHS is patients can choose to go wherever they want, technically. But I mean, I'll give you an example. I had a private patient referral from US for implant. And I said, you got so many good implanters, it's not worth coming here because it's not just putting an implant in, you need to have a follow-up. So it is better they're treated locally and they have that safety net. So the best way to do is refer to your local pain clinic. And what is your background? Are you a vascular surgeon, diabetic, endocrinology?
No, I'm actually a podiatrist.
Okay, fine. So, anyone who's treating locally, they know what they're doing. I mean, they can do almost everything. But where you should step in is when the patient is suffering, nothing else is going on, the same person is doing the same old, including pain physicians. We keep doing those trigger point injections or epidurals, and the patient is still suffering. Then you can say, can you please refer the patient to a tertiary center? And the tertiary centers are UCL, we are the largest pain clinic, Guy's and St. Thomas. They're the 2 good pain clinics that do almost everything in pain management. We are the tertiary center for pelvic pain. So if you have a patient that is struggling, has had local pain clinic input, then these patients can be referred to UCL pain clinic. If you just say, I mean, oftentimes we just get 1-letter referral, but if you just say the patient has this pain, he's had this treatment, can you please consider for further treatment, we'll be grateful. And generally we don't say no, but we do refuse if the patient has had 0 input locally. So do refer to local, and they should know the treatment pathway.
Sorry, just...
Maybe 2 years, isn't it?
No, generally not. For spinal cord stimulation, the waiting list, and that's why, if they have done the local bit and they've done everything, then the waiting list generally, we follow the 18 weeks pathway and spinal cord stimulation on the lead for the pathway, and generally we tend to see them fairly quickly. Of course, if they have not had any input, they get rejected and the waiting list becomes 2 years.
Yeah, sorry, the frames is frequency rheumatic electrical modulation system.
Yeah. So if you're referring to the different frequencies, so in spinal cord stimulation, you can stimulate, it's a electrical stimulation. Electricity is a function of voltage, amplitude, resistance, and we forget the waveform. So frequency can be 1 hertz or 10,000 hertz. So the lower the frequency, it stimulates a different nerve. So at 2 hertz, which is tense, you get that jumping sensation. So it predominantly stimulates a motor nerve. So a traditional spinal cord stimulation stimulates somewhere between 60 hertz to 150 hertz. But then in 2009, when we did the first study, Nevro came with a device that could stimulate at 10,000 hertz. At 10,000 hertz, when you put it on the nerve, you don't get any buzzing sensation. So you don't get that jerking and stuff. So traditionally, if I put an implant and you got that buzzing sensation, you're asked to switch it off when you're driving, because if you go on a hump, you don't want to get a jolt and lose control. With 10,000 hertz, you don't get that. So it is a frequency is a big factor of how you get pain relief. And traditionally, again, back pain and leg pain was the classical indication for spinal cord stimulation. And it didn't work well for back pain. So when this came in 2009, we showed that we can treat back pain with it. And then when I joined Queen Square, which is the tertiary center for pelvic pain, neurology, a lot of neurological conditions, we apply the same thing to a lot of neuropathic pain conditions, stoma pain, pelvic pain, even thoracic pain. And so there's a lot of debate going on that, and a lot of other manufacturers, Medtronic, Boston, they're all now going up to 2,000 hertz because the other company has got a patent for the 5,000 plus hertz. So everyone is trying to give that sub-threshold stimulus. I don't know if I've answered your question, but we can catch up later and we can discuss.
But in terms of the vasculature, maybe to add, I think it is a good option for no options patients. I mean, now people are discussing lymph flow and etc. I don't know why it's not done for that, because it improves it's like a sympathectomy. Or we used to do hyperbaric oxygen. In some people it works. I wouldn't know about the referral pathways in this country for that, but it is something we previously did for that, and I think it can be effective in people. Yeah.
Some of our best patients have been the Raynaud's patients, and so it's not for everyone. Look, if you send a patient who's got head-to-toe pain and got ischemic limb, and he needs a surgery, obviously, but these are patients who get this painful limb. So I don't treat diabetes. I don't treat vascular. But if it's a pain, and pain is a predominant issue, and it's a localized pain, then it's fair play. If you're in doubt, send it to me. You can call me. We can have a chat.
Thank you very much for your talk. I'm Ian Cole. I'm one of the local GPs here. Is a spinal cord stimulator available in the private sector? And if so, how much?
Yeah.
And how often do you need to change your batteries?
Okay. So this is a nice recommended treatment. So technically, if you have neuropathic pain, depending on your insurance cover, so you should be able to get it. So we do fair bit, both in the NHS and the private, and generally I've not had a refusal for 80 to 90. So I've had acceptance for 80 to 90% of my patients, which doesn't mean they say yes to everything I say. It's just that we're very strict in how we do it. So I'm in conflict of interest. I work at Cleveland Clinic, but we have an MDT. We got a psychologist. We got two specialist nurses. We even have a PhD fellow who's doing a PhD in neuromodulation. So we're not a classical paying clinic. It's an institutional setup, and we have MDT, so we take it through MDT. So what is the cost? I would err on the side of caution. The whole thing might cost you about 60,000 pounds. But it's generally covered by insurance. I have had a lot of self-pay patients. We have patients coming from Caribbean, the Middle East, the US, and that is not my fee, unfortunately. That is the device is expensive because we do so few overall compared to, say, prescribing medications. And once it is available in countries like China, India, and Asia, where the population, but it's a game of numbers. The more you do, the cheaper it becomes. And they're all fairly new therapies, so there's a huge IP cost into it. And the hospital charges double the money. If the device costs 15,000, the markup is 100%. The hospital will charge you 30,000 pounds. Okay, so it's mainly the device cost at the moment. So that is the cost. You had one more part of the question.
How often do you need to change your batteries?
Okay, so generally these are all rechargeable systems. So in theory, I've got some patients. I've been doing this since 2009-10. So I still have patients who have not had a battery change for over 10 years. But however, having said that, it's not all rosy. It's man-made. Devices can fail. The revision rate is about 7%. So it can move, wires can move, they can have a fall. So there's a financial implication. But if it's done for the right indication and you're not a cowboy, it's still covered in the NHS. So it's a very responsible thing because it's an expensive therapy. If you do too many of them and they fail, which has happened in US and Australia, there was a publication in JAMA from US where they're just implanting. That's the system they are in. Same in Australia, there was a publication where there's no control. Like UK, I think is fairly conservative. We got the NICE, we got the guidelines, the insurers don't approve easily. So our real life data, which is published, is phenomenal. And the insurers worldwide are trying to use that to get their approvals. So yeah, so I think I'll answer.
Great, thanks so much.
I just wondered if you work for Fender Limb people with amputation.
Yeah, so I was just was I telling you? So yesterday, I just followed up my patient, and it's a very difficult indication. I have burned my fingers because once you implant, they're married to you, and you don't want to implant a patient with that much of distress and stuff because you need to be at the other end of the phone all the time. You can't be. You got to. So we got a call a few months back. The patient was listed for above knee amputation, having had below knee amputation, young in the private. And the vascular surgeon said, Ash, I really don't want to do this surgery. And he's admitted for the surgery. Is there anything you can do? I just realized you're at Cleveland and you do implants. So we have implanted him. So far, so good. It's too soon because until it works for at least a year, you can't celebrate. Over a year, I'm okay. I've delayed his amputation by a year. So Yes, phantom limb pain, neuropathic stump pain are all reasonable indications, but they are one of the harder indications. Testicular pain. They're all challenging, but in selected group of patients with MDT input, we can try that. I would rather, that is not my best indication, but when it's a young boy who's going to have further surgery and he's very active in full-time employment, I'm willing to bend over backwards and see what I can do. But it's always that case. I only get the patients when the limbs are chopped off. I wish I could get them before the limbs are chopped off.
But can they go to the swimming pool?
Yes, they can swim, they can play. I mean, we had a golf player who, when we did the high frequency one, with the conventional SCS, you had to switch it off when you're playing golf because you want to. So when we did the high frequency one, we were the first to do it in UK in Guy's and St Thomas.
Before Sheffield?
Yeah, we were the first. The first study was done at Guy's and St Thomas, the high frequency. And with Belgium. So there's 2 center study, and one in Belgium, one in Guy's and St Thomas. And this is way back in 2011, 2012. We went commercial here. US did their first study in 2014 and got FDA approval in 2015. So at that time, we had a golf player who wanted to stay active. Of course, he was in his late 70s. He came down to UK to have that device fitted. So the aim of the device is not to get you down, it's to get you out. And if the pain is good enough for you to be active, don't have it. But if the pain is stopping you from doing that, this is there to get you out and active. You can't do the butterfly stroke, but it's okay to do the freestyle and the breaststroke.
So thank you very much for the wonderful presentation. This is just a question for Dr. Ashish Shetty. So do you see less invasive neuromodulation therapies sort of helping patients more in the future and potentially taking over the sort of replacing the spinal cord stimulation? Because obviously more invasive could potentially have more complications. I was just wondering what your thoughts would be on that.
Yeah, so I'm a big fan of non-invasive neuromodulation. In fact, one of my biggest practices is non-invasive neuromodulation. In fact, I'm carrying a device in my back. So I love it because I've made a lot of friends. This is the tiniest device you can use. Sorry, I've got a few devices in my bag. So this is, so I travel it everywhere. I've treated patients on the plane. I've treated patients in hotel rooms. These are colleagues and they say, I've got this pain. I was at a meeting in Croatia last week and one of my mentors has got back pain. And we put this device on while the lecture was going on. So I think there's a future, low cost, non-invasive, less complication. Is it going to replace? The technology doesn't exist at the moment to deliver the current. At the end of the day, you have to deliver it to cause neuromodulation. So this is almost a peripheral nerve stimulation. What you do proximal to the DRG, and this is my take on it, is neuromodulation. So they're 2 different things. Sometimes neurostimulation like TENS has very little evidence, but there's a saying, extraordinary claim need extraordinary proof. TENS is $50, you can use it anywhere. This is a little bit more expensive. I've got another device that costs £3,000. I've got 5 different devices. I've been a chief medical officer for one of the companies, but I didn't like the company, so I've quit, but I still use their devices. So the answer to it is yes, that's my dream too, because these are expensive, but I wouldn't agree that these are too invasive because these are simpler procedures. If you're okay having a knee replacement, if you're okay having a spine surgery, this is 1/10 of the risk. Not even that, to be fair. So, but people, when it comes to pain management, they want an immediate result, but they're okay to have this big spine surgery and they accept it. So I think the non-invasive neuromodulation, like I showed you the timeline for a reason, is the oldest therapy, one of the oldest therapy known to mankind in terms of pain management. Headaches, they used to treat, 2000 BC.
Thank you.
Yeah. Sorry, I've got it.
issues, but at the same time he has all this pain, he takes all these heavy opioids, painkillers. So I'm just wondering, when is the time we should be more alert and aware that this pain is a 50% and the rest would be neuropathy as well? It's like we see the patient every 3 weeks, 2 weeks, maybe his wound is improving, as you said, he sleeps better, his pain is better, but in the background he would have progression of neuropathy, like it's something we cannot stop.
Well, it's a very interesting question, because this kind of concept of ischemic neuropathy is to me also a rather newer one, and rather kind of I see that in practice, and now in preparation for that I realized, oh, actually there are a number of studies, and American Heart came out actually with a statement on that. So it's quite new, I would say. There are few situations where it just jumped at me. For instance, because we do the MDTs with vascular surgeons, with diabetologists, podiatrists, microbiologists, and several times I've seen people that described whatever, like numbness or pain in the foot, very weird symptoms, and also this, how's it called, when you look at pain sensation in your jaw, and
referred pain.
No, it's called
allodynia.
No, allodynia, that's not allodynia, no. No, allodynia is something when a non-painful stimuli causes pain, like, for example, pajamas and things like this.
But there is I got the wrong word, but there is a kind of, if you have ischemic neuropathy, there are a few studies that also looked at changes in your pain response in different parts of the body.
Okay, hypersensitization, central sensitization?
Yes, that's it. So, so also quite interesting that some people with severe ischemia, and I just try to do the vascular access, and they almost jump off the table. And I said, I would say, I haven't even poked you, not even the local anesthesia. So there are a few things that I've noticed. Also, kind of numb feet, no sensation in the feet, where that wouldn't qualify really as rest pain, but it improves after reperfusion. So I think it's quite interesting. There's a component that we're maybe missing, and so I don't have an answer to you. And also the question, what does it do prognostically? I don't know. Does it respond actually to gabapentin, duloxetine, or something? From my experience, to some degree, but my mindset was, and to a degree still is, if ischemia leads to pain, the ischemia needs to go first. Yeah. And what's left is then the stuff that usually the people can deal with better. There are a few people that can't, but from my patients, maybe I get a selected group of patients, the ischemia takes away a good proportion of it. And in particular, also if inflammation is then gone after a while. So I think it's really a big question mark. So I can't answer your questions. To be continued, I would say.
What I find profoundly depressing is that the drugs you mentioned, the medical drugs, have all been around for a very long time, and they're very ineffective. And I was hoping you were going to tell me the new developments. We're all waiting for new generation of analgesic drugs, TRPV1 antagonists, sodium channel blockers, nanoparticle and enkephalin delivery. What are your thoughts on newer drugs that are going to work better? And that's the first question I have, because it's a very depressing situation medically that all the drugs you've mentioned, none of them, I suspect, were patented in the last 20 years.
You're absolutely right. I mean, as I said, at its best, these drugs cause 50% of pain relief. And, obviously, I showed you the latest trial, which obviously used the current drugs which are being used, and these are being obviously approved by NICE. But I don't think, are you aware of any newer drugs,
Yeah, so, I mean, there are a lot of newer drugs, but it's so expensive, you cannot give it out to the population. So, for example, disease-modifying drugs. So, with pain, we don't, I mean, to be fair, we don't understand the brain that well. And with time, we realize that the glial cells in the brain have a profound role in modulating a lot of this pain. The central sensitization mechanism and so on is still a theoretical explanation. But they have been working on disease-modifying drugs for a long time. They've been working for optogenetics, which is modification with light. It's a different form of neuromodulation. But they're also expensive to carry out the trial itself. And so they're not past the initial stage of trial yet. So I think there's hope, but it's the cost that is stopping us at the moment.
Could I ask you one other question? Tipu Aziz died recently. What do you think about periaqueductal grey stimulation? It's gone out of fashion. Is it going to come back?
I don't know. I was going to talk about my, we are running a Advanced Interventions in Pain Day on 5th of June. I think they'll bring up the slide in a short while. And Harith Akram, one of the neurosurgeons from Queen Square, is going to talk about some of those, including brain surgery for pain, periaqueductal stimulation, and so on. So he is the person. In fact, he's the guy who's also doing the Neuralink study for Elon Musk. So we are covering some of that as well. It's theoretical. It's a little bit. So I don't want to answer on something that I'm not an expert on. I might tell you the wrong things. You have someone there had a question. Yeah, go on. We can hear you.
Okay, yeah. Now, I just wonder on the theory side, this spinal cord stimulation, has it validated Mouse and Wall's gate control theory of pain?
Has spinal cord stimulation validated
Mouse
the gate
and
control
Wall's theory?
Yeah, so I mean, Melzack and Wall, one of them is a Canadian, one of them is from UCL.
Yeah.
So yes, the spinal cord stimulation works on that theory, which is still a theory. Personally, we've been working on pain pathways stuff, which we think the pain pathways that have been described traditionally, probably it has to be revisited. But the simple answer to your question is yes. There's a question. Yeah.
I've got a question about sort of psychological therapies, mental health. I think there might be a little bit of a role here for like dopamine, because if you enjoy doing something, you want to keep doing it, right? So the internet addiction and the social media is getting a bit out of control. I think we're fueling obesity from that particular situation. We used to be much more mobile. I'm a perfect example of BMI in the wrong direction, okay? But part of this wanting to do something and being aware of what could happen is a really important conversation, because people go, oh, I've had enough of doing all this juggling and all this kind of thing. I've had enough. And that's when the danger hits, because a lot of these things are without symptoms, and then we develop a whole heap of complications. So it needs to start right at that situation before we even have a diagnosis. What could this be? How can we manage this while we're waiting for that appointment, so we stop people piling into A&E? Thank you.
I think exactly that's what clinical psychologists and clinical therapists do. King's College have got quite a large department dealing with this issue. They use CBT, they use coping strategies, and they have a lot of techniques in that area.
Can I just add to your earlier point as well? You mentioned diet and lifestyle. You'd be interested to know that the big food industries, the people that make Pringles, Doritos, they have neuroscientists and psychologists on their food development teams. So, they assess things like the crunch, the bite, the color, the taste, the smell, and something called the bliss point, which is the mixture of fat and sugar in food. So we all know how woefully underfunded mental health services are in the NHS, particularly by the time they've developed diabetes. We have, Dr. Lakhdar and I work in a unit where we're lucky enough to have a diabetes psychiatrist and diabetes psychologist, but it's almost too late by the time they're seeing them and us. So you're right. This, the constant quest for dopamine that begins earlier and earlier in modern life. It's a real public health disaster, and I think governments across the world need to do more. Part of the problem is big food industry and the money it generates. Yep. 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 Yeah, we are. It is. Absolutely. Because Doritos cause a dopamine release in the brain, a broccoli doesn't, a piece of broccoli doesn't. That's because we have been eating vegetables for hundreds of thousands, millions of years, and it's not meant to do that. So yeah, we're in a public health crisis. I mean, I know this is not really the topic of discussion for tonight, but it's kind of the thing that we don't really talk about, right?
But if I can comment on that because I agree to some degree, but just from there's like another angle to me, because if you eat that Doritos, I'm also convinced that yes, it will give you an immediate pleasure, but it will also give you the down afterwards.
Yeah.
So it and if you, for instance, eat things with a slower release, whatever, eat the broccoli and drink your tea, you don't get that, but overall you feel better. And so maybe that's also a culture thing, that you don't, that you kind of need to relearn, that you don't crave the. And there's also some work being done with blood pressure lowering, and some colleagues of mine just published it, that blood pressure lowering medication also to some degree takes care of ADHD symptoms. So because in a way we're calling our patients, say, don't do this, don't do this, don't do this, and the negative messages don't work. But I think the only way to swing it around is to come to positive health messages. And I think if you go for foods that drop your blood pressure, if you look for it, you will feel that you actually feel better. And so there is that degree of learning. I think I want to see it positive.
And it goes back to education, doesn't it? So it goes back to public education, public health. It is.
Yeah, we can't fix the government here, so
down,
anything with
it?
science we
they hit high pay, they eat a bag of sweets, then it goes high, and then it wears off, it's balancing all of that.
You know, I work in East London, and the average East Londoner that I'm seeing is just trying to get through the day. They're just trying to make ends meet, and it's really difficult to counsel people about this sort of bigger picture thinking. Yeah. It is.
Do we have any other questions?
Any other question, please?
So before we finish, can they bring up the meeting slide? So I was terribly upset that I only got 20 minutes to speak today. So I'm running a full day.
Yes, he was. We had the discussion about that. When we said, can you focus it on 20 minutes? You said, I need a whole day.
So I'm running a whole day meeting here at the RSM. And if there are any trainees, I'll personally sponsor the meeting, because part of the education is educating doctors. We keep blaming everyone else. As patients, we don't take responsibility. As doctors, we don't take responsibility to look at the guidelines. So as a part of my bet, I'm running the meeting. If there are trainees, I'll fund it myself. Please reach out to me. If your trainees want to come, let us know. And we're doing advanced interventions in pain. We will cover everything from spinal cord stimulation to cryotherapy to brain surgery for pain management. And that's a taster day for me. So and if anyone is desperate and they want funding, we'll try that too. So thank you.
Right. I think it's time now to close this masterclass meeting. I hope you enjoyed the presentations, the discussions, the interactions, because I certainly did. So may I thank you all for coming. Thank my colleagues, and in particular, I would like to thank the partnership of the Alan Sheila Diamond Charitable Trust, Alan and Sheila Charitable Trust, the Food and Diabetes UK, the English Diabetes Food Network, and the Diabetes Research and Wellness Foundation. And I thank you all, and I close the meeting.